Good day, everyone. Sorry, can you hear me? Can you all hear me?
Yes, I can.
Okay. Good day, I'm Festus, the Concept Academy. So I will be flipping through the cardiovascular step 2. We continue from wherever we stop. Just as I always say, we are not in any way projecting ourselves as the specialist of the field. We are only trying to help. So if at all you expect us to say it in a particular way and we do not say it that way, please don't be annoyed with us. So we are only trying to help. Okay, so this is congestive heart failure. So this is congestive heart failure. So I will just be making the important points you want to take into the exam, and I want you to pay attention to them. I know some of us we have the knowledge already, but you will gain a lot from whatsoever I'm going to unravel for us, both in the exam and also in practice. Okay. Heart failure itself is a syndrome. It's more or less like what the patient is presenting with. That's what you put together and you say this is heart failure. So what that means is that there can be so many causes. Do you get it? So cardiomyopathy might be a cause, infection might be a cause, and the likes. So the reason why I need to make that point clear is because when you read a question in that exam, you see the heart failure before you start shouting on top of your voice that is heart failure, heart failure, heart failure. Heart failure itself uh, is not really a diagnosis, so to say. So it's just everything you are seeing all together, you put it under heart failure. But there must be a cause that you need to peg on it. So is it as a result of hypertension? Is it as a result of cardiomyopathy? Is it as a result of valvular heart disease, diabetes, and so many other things? I mean that you can talk about or think about. So that's heart failure. So we have so many ways of classifying heart failure, but for the purpose of this exam, you want to write. Um, One of the ways is just based on the ejection fraction. So in step 2, we already know how to calculate ejection fraction. So it's more or less like the volume that is actually pumped out of the heart divided by the volume that is inside the that is loaded into the heart. So usually says the stroke volume divided by the end diastolic volume. So that's the ejection fraction. So in this exam you are going to write, they will quote ejection fraction for you, and based on the ejection fraction that is quoted, you will use that to determine what kind of heart failure you are dealing with. So we have left if you if you have the ejection fraction lower than 40%, this is an error actually in first aid. So this is an error. It's not greater than 40%, it's less than 40% they wanted to type. So if you have the opportunity of messaging them and letting them know that they have an error in their book, so they will correct it. So this is less than 40. So if left ventricular ejection fraction is less than 40%, you call that heart failure with reduced ejection fraction. So that's just what you need. So in that exam, they will quote the ejection fraction for you. Once you see it, you just say, okay, this is reduced ejection fraction. They can give you 20, they can give you 25, they can give you 30, 35, 38, 39. So whichever one they quote for you, you realize that it's less than 40%. That is going to be heart failure with reduced ejection fraction. This is another name for it, systolic heart failure, because it shows that the heart is not really contracting the way it should. the heart is not really contracting the way it should. Now, that's just more or less like the background information. If you look at everything I've said so far, it's just more or less like how the question will present. So you will see they will give you the ejection fraction. You will just quickly check the value. Is it less than 40 or not? So we've not really given you what you are expecting in terms of what they want to ask. Now, when you see that the heart failure is the heart failure with reduced ejection fraction, you must treat aggressively. In fact, you must treat aggressively. You don't want to wait. And this is my first point with you today. So that anytime you are looking at this, you want to pay attention to this fact. You must treat aggressively. You do not want to wait. You must treat aggressively. You do not want to wait. You must treat aggressively. You do not want to wait. And the kind of drugs you are going to now be looking for amidst the options, they are usually mortality. They usually have this mortality reduction benefit. So when you place the patient on those drugs, the drugs will reduce the tendency of death in the patient. Okay, now that I've made this statement now, what are these drugs? Mortality reducing quadruple therapy that you must never forget when you are dealing with left ventricular ejection fraction that is less than 40%. So, and the patient is in heart failure. These are the drugs. I put them under the mnemonic of SAME, same. So, same. SE is SGLT2 inhibitor. So, these are the dapagliflozin, empagliflozin. So, they will reduce heart failure hospitalization, but they are also going to reduce death in the patient, tendency of death in the patients. So these are the drugs we'll be looking for amidst the option. They have mortality reduction benefits. A is just this angiotensin receptor neprilysin inhibitor, so or ACE high or ARB. So any of them that you place, if they put amidst the option, will also reduce mortality. If you see, look at the options very well. They will just ask you in the exam, which of the following medications will reduce mortality in this patient. This patient will heart failure with reduced ejection fraction. You just look and pick. M is mineralocorticoid receptor antagonist like spironolactone, eplerenone. So if you see that also, is going to reduce mortality. Then evidence-based beta blocker. That's the E. Evidence-based beta blocker. So carfentanil, metoprolol, bisoprolol, any of them that you see, you pick that. So these 4 drugs, I will advise you to put them at the back of your mind, not only for the 4 set of drugs, not only for the purpose of the exam, but for clinical practice. So that when you are reading any question on heart failure, whether for Canadian exam, for Australia exam, for United States, for United Kingdom, I don't care, even for Africa exam, so you want to pay attention to these guys. Once it's actually the heart failure with reduced ejection fraction. So these are the things I want you to really put at the back of your mind. Sorry, 1 minute. So these are the things I want you to put at the back of your mind. Don't forget these 4. Just rehearse them, say them, and write them down. Okay, now we have these 2 sets of heart failure again. You can have what we call this heart failure with reduced ejection fraction, just as we said the other time. Then we have the one for preserved ejection fraction. This is just a table, but I think I should come back to this table when I'm done with both of them. So now, if you look at the ejection fraction, and the ejection fraction is between 41 to 49, so usually put that one under moderately reduced ejection fraction. So heart failure with moderately reduced ejection fraction. All right, so if you check the question and the ejection fraction is 50 and above in a patient with symptoms and signs that you can peg on heart failure, so you call that heart failure with preserved ejection fraction. So now, for the purpose of this exam you want to write, they will not ask you really about the heart failure with moderately reduced ejection fraction. So the one they are going to ask is basically the reduced ejection fraction and preserved ejection fraction. Now, how are you going to treat the moderately reduced ejection fraction? You just look at how the patient is presenting, basically, usually following the one with reduced ejection fraction, because the way they present is usually or roughly the same. So your mode of treatment will follow the way you treat heart failure with reduced ejection fraction. Now, for the heart failure with preserved ejection fraction, your main mode of treatment is to treat the comorbidity. That's the main thing. Treat the comorbidity. If the question says, they will just give you the question, and you will look at the ejection fraction given to you, you realize that ejection fraction is let me say 55, and you are seeing symptoms and signs of heart failure there. So you say this is preserved heart failure with preserved ejection fraction. So now say, what do you want to do? Flip through that question again. Quickly check for comorbidity. It might be obesity. It might be hypertension. It might be anything. Whatsoever you see there, that is what you need to pay attention to in that clinic. So when the patient comes to you in that clinic with the heart failure with preserved ejection fraction, and you are looking at that patient, look for comorbidity. Check. Are you having sleep apnea? Yes. I'm having. Treat it. Focus on that. That is your main thing. Look at the BMI of that patient. If it's high, that is your main thing. Whatsoever you are seeing there, that is what you focus on. That is the principle. Now, is there any other drug you want to add to the drug? If you look at the one with reduced ejection fraction, we have 4 wonderful set of drugs that you can use to reduce mortality. However, in preserved ejection fraction, it's only one that have been discovered that can reduce mortality in them, and that is the SGLT2 inhibitors, dapagliflozin, empagliflozin, and the likes. Those are the ones you see. All those other drugs you see with reduced ejection fraction, they are not applicable here. Now, amidst the 3 of them, which one are you now specifically most likely they will test me on it? It is this one with preserved ejection fraction. Watch out for it in the exam. So, and the drug they will test is this SGLT2 inhibitor. So when you get into the exam, you look at the question, check for the symptoms and signs of the heart failure that you will see. Do you get it? So check for those symptoms and signs. When you see them, you quickly check for the ejection fraction. If it's normal, it's within normal or high, so you say this is preserved ejection fraction, and from there you already know the drug they are most likely testing. And if they are not testing any drug, you quickly check for any comorbidity and you address that. Is there any other thing again that is peculiar with heart failure with preserved ejection fraction? And that thing is usually you will see natriuretic peptide very high. As a general rule, as you are going into the exam, you are reading your wonderful question and chewing your cola nuts inside the exam. The question is long. You now flip your eyes and see elevated natriuretic peptide, BMP. They give you BMP is 800 and something, 900 and something. They just quote one very big value for you. Until proven otherwise, that patient is in heart failure. Can you see the way I said it? That patient is in heart failure. I'm not saying whether reduced ejection fraction or preserved ejection fraction until I check for the ejection fraction and I see it. So once you see elevated natriuretic peptide, whether AMP, BMP, usually BMP they will quote for you, you will go for heart failure. You know that that patient is in failure usually. Okay, now, so this is now the one for reduced ejection fraction. This is the one for preserved ejection fraction, this part of the table. If you say it's reduced ejection fraction, it shows that the heart is not contracting enough to push out enough blood. That's why the ejection fraction is low. So you call that systolic heart failure. Systolic heart failure. I represent systolic, letter S as letter C. So just for you to know that this is the third letter of the alphabet, and you will be hearing S3 heart sound. So when they write the question for you, and you see, they will give you the symptoms and signs of the heart failure, they will now say that they are hearing S3. Once you see S3 in the question, most likely you are dealing with systolic heart failure or heart failure with reduced ejection fraction. Systolic heart failure, they call it systolic heart failure because the systole has failed. The heart is not contracting. That's why you call it systolic heart failure. And when you check the patient, usually you see the patient will be less than 65 years of age. I put this in red because in a question, they've actually we've seen a question where the age will quickly give it out for you without too much detail. So you can see less than 65. You can see letter C is basically lower than letter D. So this will be less than 65. This one will be more than 65. So if the heart is not contracting, so you realize that the heart will now be dilating. Do you get it? So if you are linking it with dilated cardiomyopathy, that will not be a bad idea. If you are linking with valvular heart disease, it's also not going to be a bad idea. Or hem high. The heart will just be dilating, will not really be able to contract. And you know why the heart will not really contract in myocardial infarction? Because the source of energy for contraction has been lost because of the infarction. Now, when you examine the patient, you will see displaced point of maximum impulse. When you see this displaced point of maximum impulse, you already know that the heart is bigger than normal. So that is like dilated heart. Can you see? And you see that in heart failure with reduced ejection fraction. All right. So in this one, you will see cardiomegaly, which is also pointing towards the fact that the heart is big. You load 100 mils into the heart. Heart normally is supposed to push out maybe 50 mils, and the heart is pushing out 10 or 20 mils. The remaining mils will make the heart to now balloon out. So cardiomegaly. So that's heart failure with reduced ejection fraction. So now, why am I emphasizing all these important points? I'm emphasizing them because when you read your question, you can quickly know whether this is heart failure with reduced ejection fraction or not, even if they don't quote ejection fraction for you, by seeing cardiomegaly, by seeing displaced point of maximum impulse, and the like, or by looking at the age of the patient, or they are mentioning history gallop. So that will point it out for you. What about the heart failure with preserved ejection fraction? Usually the heart wall is very thick. It's thick, usually. That's what you have there. So if it's thicker than the way it should, the heart cannot really relax the way it should normally. So you call that diastolic dysfunction or diastolic heart failure. Can you see? So this is systolic heart failure, diastolic heart failure. Letter D in the alphabet is the fourth letter. So that will be S4 heart sound you will hear. So when you read the question, you now see S4. You just see this is diastolic, this is heart failure with preserved ejection fraction. So the kind of comorbidity you can see, it can be anything. Anyone you see there will be the answer, depending on what the question is asking. With the heart be big here, usually you don't see cardiomegaly. Usually you won't see cardiomegaly. So when you read the question, they quote cardiomegaly for you. You already know the kind of heart failure you are dealing with, systolic or heart failure with reduced ejection fraction. And you already know the kind of drugs they can also test there. I've mentioned them. All right. Now we come to another way of classifying heart failure. We usually say left-sided heart failure or right-sided heart failure. So the way you look at this one in the exam, for those that are not used to it, is that this is the heart and this is the lung. This is the lung. So this is the left part of right part of the heart. This is the left part of the heart. So this one should push blood to the lung. This is lung. Why this one we push from the lung is supposed to come to the left heart, then it will pump it to the other part of the body. So where is blood coming from? The blood is coming from the venous return here, can you see? Then from here it will push it out to the other part of the body from the left heart. So now when you say that the patient is having right heart failure, so what it means is that this right side of the heart is not pushing blood towards the lung the way it should. So first of all, you are not likely going to see respiratory symptoms, lung congestion. You won't really see respiratory symptom in the question. So but you will see the other symptoms as sign you can put on or peg on heart failure. So what are those things you will now see? If this right side of the heart is not pumping the way it should, what it means is that the venous return will also not occur the way it should. And with that, venous congestion will now start occurring. You will start seeing that. So you will be seeing something like hepatomegaly. You will be seeing something like ascites. You will be seeing something like edema. You will be seeing all those kind of stuff. But when you check the question, you will not really see anything about the lung. Maybe and they are listening to the lung, they are now picking crackles. You won't see that. And the patient is having maybe a level of breathlessness and the likes. It's not really that common. So, but you are going to see venous congestion, whether from in the name of hepatomegaly, ascites, edema, and the likes. So that's when you know that the right heart is the one that has failed. So right heart failure, that's what you will see here. So when you get into the exam, you are only looking for symptoms related to the lung. That's the only thing you are looking for. We know you love to look for so many things. You want to prove to the world that you have, like, we know. But for the purpose of the exam, just quickly check for, can I see anything related to the lung here? Once you can bring out anything related to the lung there, you are likely dealing with left heart failure or congestive heart failure. So let's look at the lung, the left now. So for the left, the heart cannot pump blood to the systemic circulation. So which means the left ventricle will just be loaded with blood that cannot go, that cannot leave it, that cannot be pumped out. Then the next thing you see is that the blood coming from the lung cannot really empty effectively to the left heart. And the next thing is that the blood, you now have a lot of stasis within the lung. So that is where, before you know, you start seeing pulmonary hydrostatic pressure will start rising, favoring the seeping of the fluid into the lung interstitial spaces. And the next thing you see is crackles. So you just start hearing crackles everywhere. So when you read the question and they say they listen and they are picking crackles, so most likely you are dealing with left heart failure. All right. Something just related to the lungs, usually lung. All right. So if you look here, you are seeing bilateral basilar rales, pleural effusion, pulmonary edema, autopnea, paroxysmal nocturnal dyspnea, all those kind of stuff. Just something related to the respiratory stuff. So that will give it out. What if you now look at the question, you now see something related to venous, systemic venous congestion, and you see something related to the lung, respiratory symptoms there. Two of them are together. You call that congestive. It's like both of them, both the right and the left are involved. Can you see? So that's congestive. So when you get into the exam, you are quite systematic in the way you look at the question. When you are clerking the patient, you are also systematic in the way you are asking the question. When you are reading the options, you are also logical in the way you are looking at every option. What am I seeing? Is it something related to respiratory? Usually left. Is it something related to venous congestion? Right. Is it both of them? Congestive. And that's that. All right. So that's about the. There is also another way you classify the heart. Usually, the way you look at this is we have what we call the acute heart failure. We have chronic. I will just peg them on those two for now, just for simplicity's sake. You can now be going into acute, decompensated heart failure later. So when a patient is diagnosed of heart failure, usually you don't undiagnose them of heart failure. When you see a patient today, the patient, you diagnose acute heart failure for this patient. Maybe that's the first time the patient will be having it and the patient is coming down with a lot of manifestation. You quickly treat the patient. You don't usually undiagnose. Yes, we know you are the best cardiologist on earth. So when you are done treating, you do not undiagnose that heart failure, that the patient has been cured. The patient usually don't get cured. They just have their conditions being managed. So when you take that acute heart failure, you give your drugs and the like, you treat the patient. The patient that was initially breathless is now shouting, "Doctor, what is your name? Can I have your number? You are this, you are that." That patient, you have moved the patient from acute, usually to chronic. Get the logic there. So when you see a patient with heart failure for the first time, having it for the first time, usually peg it on acute. When you are done treating, giving all your drugs, you don't undiagnose that heart failure. You only move the patient from acute to chronic. The patient is still having heart failure, because the patient, what you can do, the exercise you can tolerate, whether the patient was, no matter how, the patient cannot do them. That's it. The patient cannot do them. Whether the patient looks normal or not, the patient cannot do them. So the heart failure is still there. It's just that the patient is not having maybe exacerbation of the symptoms. Don't forget that all those symptoms, they are the ones you call heart failure themselves. All those symptoms, all those manifestations, even though the patient is not having those symptoms. So they are managed by drug. Do you get it? So you don't change the diagnosis or say the patient has been cured. So when someone is sharing a testimony and the person is like, yeah, initially I was breathless, this and that, but now I can do this, I can do that, my heart failure was cured. Yes, miracles happened. Happened, but it doesn't mean the heart failure has been cured. It's just controlled, it's managed. So you advise the patient not to stop the drug. So the patient does not stop the drug, because if the patient should stop the drug, the patient is likely to relapse. All right. So that's how you look at chronic. So when you get into the exam, you look at acute and chronic. They mention them in the question. Chronic is just telling you that the symptoms are not really there, but the patient suffered it before, and the patient is presently on drug. All right. That's for the chronic. What about someone that has been normal? Presumably normal, symptoms free. That's what I mean. Heart failure, chronic heart failure. Suddenly, by one reason or the other, the patient now develops something acutely. The symptoms just come up again, having breathlessness, this and that. You call that acute, decompensated heart failure. Can you see acute decompensated heart failure? Can you see the way you bring in the acute decompensated now? So that's how you look at it. Now, what about the X-ray? Because usually on the X-ray for acute, you will see all manner of conjunction, that something you can use to characterize the conjunction, whether something related to cavitation of the pulmonary vessels and the likes, and all manner of stuff. You might even be seeing some fluid and the whatsoever you are seeing there. You just know that this is heart failure. However, for the chronic one, you will not see that. You don't usually see all those stuff. In fact, the X-ray will look normal. So if you look at the X-ray and they report it normal, for someone that was previously diagnosed, everything is normal. Now, the doctor, am I normal now? Am I normal now? Now say, yes, you are normal now. No, the patient is not normal. The patient is just controlled. The patient just has all the symptoms and signs improved. It doesn't mean the patient is like you and I. So don't forget that X-ray is most likely going to be normal on chronic, but it doesn't mean the patient does not have heart failure. So we have this New York Heart Association classification. So this one is not that maybe you need to cram it per se, but it's better for you to know. I just must know, because they can put some classification for you in the exam. Not that you must don't inconvenience yourself that much. So it's something that you can still find your way around. So class 1, usually a patient that you put on class 1 New York Heart Association classification of heart failure, they have no symptoms, no limitation of activity, nothing. Like they look basically okay. So you may see someone normal on the road. The patient might already be having heart failure, but it's just on class 1. All right. So nothing, like basically normal. So when you read the question, they mention New York Heart Association classification class 1. You already know what that means. So that's class 1. For class 2, you just slide. So usually they are comfortable at rest, and they will just be having some slight limitation of activity. And when they complain to you, they will just say, I'm just getting tired. And sometimes when I walk a very long distance like this, I usually start becoming a little bit breathless. But it's not really. Once I rest, I am okay. Do you get it? You just make that complaint. So a doctor that doesn't really know much will just be like, okay, just be taking life very easy, be taking life very easy. Whereas something is already going on. All right. So if possible, if you are related to them, you just ask them to go and do some investigation just for you to know what is going on. And one of the things you are going to do, basically, when you have, apart from ECG, echo, the next thing, don't forget the lab, AMP, and the like, and BMP. You check all those stuffs. Check the kidney, check everywhere to know wherever the source is coming from. So that's for the class 2. What about class 3? If you look at it, marked. I can take this and turn it to letter M. Marked limitation. Marked limitation. Marked limitation. Marked limitation of activity. Comfortable only at rest. So marked. Once they walk a small distance, they are tired. They need to rest. Okay, what about class 4? Even at rest, they are not even okay. Even at rest, any physical activity. So if you write class 4 like this, so it's like inverted A. Any physical activity. Any physical activity. So that is class 4. So if you close your eyes, you imagine it. They mention class 4. Immediately, you don't even think about it. Just any physical activity. Because this letter V, this V, you can look at it like inverted A. Y3, you can look at it like M. 3. You have 3 limbs in letter M, so you can look at it. So this marked limitation of activity, comfortable at rest. So if you look at class 2 and 3, they are actually okay at rest. But class 4, they are not okay at rest. Class 1 look basically normal. So that's for that. All right. I've mentioned systolic dysfunction or heart failure with reduced ejection fraction. You already know what it means. You just look at your duty is just to check the question. You see the symptoms and signs of heart failure, and they will now quote for you the left ventricular ejection. They will quote it. It will be given. It's not that maybe first or that is saying it on, so it will be given. So you will see it. And when you check the left ventricular end diastolic, follow is usually going to be high. Don't forget that the first volume that was loaded to the heart, most of them were not really removed. So you now load another one to the heart. So the end diastolic volume will now look bigger than what it was before. If you look at it, the thing will be progressively getting worse. And that's why when you see this kind of picture in the question, you must treat aggressively. All right. So I'm not really going to bore you with unnecessary detail here. I won't really bore you with, but I'll just try to put it simply for you. When you say the heart has failed, what does that mean? What is heart even supposed to do ab initio? The heart is supposed to pump blood, enough blood to the entire part of the body. So if I say the heart has failed, it shows that that duty is not really being done. So what it means is that the blood is loaded to the heart, but the heart is not really pumping it out. The cardiac output has dropped. So the cardiac output reduction gives you an impression into heart failure. Don't forget what we say. Whether you are dealing with heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, both of them have reduced cardiac output. We are not talking about ejection fraction. Cardiac output itself, what is the volume that is pumped out? Do you get it? In 1 minute. When you look at that, it will be reduced compared to normal in both of them. So however, the heart failure with reduced ejection fraction is reduced. The heart failure with preserved ejection fraction is preserved. Now when the cardiac output has reduced, what usually happens? Let me just come here. When you look at the heart failure with reduced ejection fraction, the blood is loaded to the heart, is not going out. So there will be volume overload. There is reduced cardiac output. And the next thing you also see is the heart wall will be stretching out. So you have myocardial stretch. There is volume overload. There is reduced cardiac output because the heart is not pumping out. Then there is myocardial stretch. All right. So from the reduced cardiac output, that will cause reduced perfusion. Can you see? That's the effect of this thing. You will see reduced perfusion. And when there is reduced perfusion, the next thing you are going to see is sympathetic nervous system activation and RAS. You remember? RAS and sympathetic, they will be activated. The RAS, we want to retain salt and water because the way the body will picture it is that there is not enough blood in the body. They will not know that most of those blood are retained in the heart. So you just be like, there's not enough blood, kidney reabsorbs more of sodium, reabsorbs more of water. So RAS will come into play to do that. Then sympathetic nervous system activation. So that's when we release a lot of norepinephrine out and the likes, which will now favor vasoconstriction. So if you look at it critically, you realize that salt and water retention will favor increased preload because more volume will now be going towards the heart to worsen it, while the vasoconstriction will now increase afterload. The heart will now be pumping against a lot of resistance. So which means that activation of RAS and sympathetic nervous system actually worsen heart failure. Because the heart has failed, you are still loading more blood into it. The heart has failed and you are still telling the heart to pump against more resistance. The heart is going to, the condition, the symptoms and signs you will see will now worsen. All right. What about the myocardial stretch? You see, this God is so wonderful. God is so wonderful. In everything you see, you read, you look, you hear, you always see his hand there. And he's always providing escape routes for every problem that human beings will encounter. So if at all you are having any problem and you think that's the end, check well. There is always an alternative route. It's always there. That's one thing you will notice. Medically, I don't know, I don't even care, whichever field, there is always an alternative route. There is nobody that is meant to be stuck in this life. There is no condition that is meant to get anything stuck. There is always an alternative route to, to ameliorate that problem. It's only if you choose not to pay attention to the solution that God Himself is pointing your attention to, and be like, if this one has failed, I've already put this thing there for you now. Why not? And you are still saying, I don't need it. That is when there will be a problem, and that problem will persist. So what am I trying to say? Anytime you are encountering any problem in life, and you think that is the end, as a matter of fact, that is not the end. That's not even the end at all. Most likely, God is just trying, is just even beginning to now show you another alternative route. Do you get it? All right. So the reason why I mentioned that is that God already knew right from the beginning that at a point the heart will fail, but He put a system there to checkmate it, and that is the stretching of the myocardium. So anytime the blood is accumulating in the heart, and the myocardium is stretching out, let these two guys be released: AMP, atrial natriuretic peptide, and brain natriuretic peptide, AMP, BMP. Let them be released. So when these guys are now released, USMLE will always ask you around these guys, because they are the main thing. They will also ask you around these guys because they are the bad guys. They will always. You are also going to write book on it. If you are in cardiology, you can't say you don't like it. You will write something. You will talk about it. RAS and sympathetic nervous system, I now want to reduce it. I want to inhibit them because they are worsening the heart failure. Why this AMP and BMP? I want to increase them because they are reducing the worsening of the heart failure. What will the AMP and BMP do? Question number 1 you should expect in the exam. They will cause vasodilation, number 1, and they will cause salt and water loss. That's why they call them natriuretic. Natri is coming from sodium. Uretic is like they are being lost together with water. So salt and water loss. If salt and water is being lost, what it means is that the load, that the preload on the heart will now be reducing gradually, and the heart will be saying, thank you. The vasodilation will oppose this vasoconstriction here. Can you see the way? So your duty is now to increase the level of AMP and BMP in the patient's body and reduce the level of RAS and sympathetic nervous system molecules. Can you see? So that's what will happen. Now, if I now want to develop set of drugs that will reduce mortality in this patient, now the drugs must be inhibiting RAS and sympathetic nervous system, and the drug must be raising the level of AMP and the BMP. So you don't now need to cram any drug. You just need to think and pick. You look, you think, and you pick. So something like ACE high is going to inhibit RAS. ARB will inhibit RAS. Beta blocker will inhibit sympathetic nervous system. Can you see the way you are looking at it? And that's how you will look at all of them. Neprilysin inhibitor. Neprilysin is supposed to break down AMP and BMP. Neprilysin is supposed to break down AMP and BMP. So when you inhibit it, the AMP and BMP will not be broken down. The level will now start increasing. So neprilysin inhibitor, can you see? We raise the level of AMP and BMP. Can you see the way you look at it? So these are now the drugs that will reduce mortality in this patient. So your question will now revolve around these guys. All right. Why do you want to ensure you tackle this, most especially this one that we all seen it? Because if you leave the sympathetic nervous system for a very long time, cardiac and vascular remodeling will start occurring. You see, vasoconstriction for a very long time. The heart will be pumping against resistance. Hypertrophy of different dimensions will start setting in. All because the sympathetic nervous system is there for a very long time. Activation is there for a very long time. So I put it here. Look at the heart failure will reduce ejection fraction. RAS activation will occur. Sympathetic nervous system activation will also occur. Can you see? And don't forget myocardial stretching is also going to occur. And that's supposed to negate everything that these guys will do, will bring. I've told you about the S3 gallop in question. The next thing I must tell you is this, that you must know is this. When the cardiac output reduce, the body is picturing itself like, there is not enough blood, there is not enough this, there is not enough that. So the brain interprets that and increases the level of ADH, antidiuretic hormone. Can you see? Antidiuretic hormone. And that ADH, what is it going to do? It's going to cause reabsorption of water. It's going to cause reabsorption of water. I want you to get the gist very well. RAS is already activated. Sympathetic nervous system is also already activated. But because of that reduced cardiac output again, brain also comes into play and be like, I'm also not receiving enough. The brain will also increase the level of ADH release. And what will that one do? Never forget it. That ADH will now cause reabsorption of water. But RAS is also causing reabsorption of sodium and water. ADH is causing reabsorption of water. So we have more reabsorption of water than reabsorption of sodium. Because you have more reabsorption of water than reabsorption of sodium, the patient is most likely to lapse into hyponatremia. Because there will now be more or less like a dilutional hyponatremia. More water compared to sodium. More water compared to sodium. So there will be more reabsorption of water compared to sodium. That will now cause hyponatremia. So now, USMLE step 2 will test you on this hyponatremia in the exam. Once you read it, that question, and you see hyponatremia there, it is an indication that the heart failure is worse. It's a predictor of mortality. Festus, tell them again. Yes, I will tell you again. It is a predictor of mortality. The possibility that that patient will have the worst possible outcome, which is death, is very high. All manner of adaptations are failing. And that's what's going on. So if I thought you are going to address that, you will. So anytime you are reading your first aid and you see key fact, it means that, note it. It has been tested before. So this is a question you should expect again in the exam. Hyponatremia. That's why I just put it in red. What is they will just give you the lab finding. Once you see that the sodium level has dropped, you want to quickly correct it, because if you don't correct it, the possibility that the patient will die is high. How do you even correct it? How are you going to correct it? You correct it the same way you correct hyponatremia. You correct it the same way you treat hyponatremia. You also want restriction of fluid intake. Never in your life will you give this patient normal saline. All because you feel the patient is dehydrated from heart failure. Okay, now let me push normal saline. That might even worsen it. Hypertonic saline, fluid restriction, that is where this one will now come in. Never forget that hyponatremia is the predictor of mortality. It will be tested. How do you make your diagnosis in the exam? I've already told you, you will see symptoms and signs of heart failure. Beyond that, they will give you the ejection fraction for you to know which one am I dealing with. Is it reduced or preserved? Now, which investigation will they test you on in the exam? The investigation you will be tested on is echo. We know you love to cram a lot. ECG, you've already mastered everything. Chest X-ray is there, the one they will test in the exam. Once they list all those symptoms and the like, just ask you which of the four, what's the best next step here? If echo has not been done, that is your answer. Echo, 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 echo the echo. Because it is the best initial test you must not forget for the exam. If you like, you can forget this ECG, chest X-ray, and the like. They will not ask you. But you see this echo, they will ask. The reason why they don't want you to see heart failure and be shouting, go and do chest X-ray. They do not want you to have that kind of mentality. That's why it is the one they will test. It is the one they've been testing. It is the one you will test when you become the program director. Echo, 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 echo the echo. Don't forget it. Okay. The next important investigation that you do not want to forget is the lab abnormalities. Lab abnormalities set of you want to bring out. So what are those things? Brain natriuretic peptide. It will be given in the exam, and this will help you to diagnose heart failure quicker. So when you read that question, you just see BMP. You just say, this patient is in failure. The next thing, so this is, if you look at this arrow, is very thick compared to the one I put beneath it. So don't forget the sodium. 2, you must watch out for it. So when you do the electrolyte, urea and creatinine now, and it's normal, it doesn't mean that you stop checking for it. So next time again, you also want to check for it to see how the patient is doing, because the sodium that was normal before might not be normal the next time. What if the patient is not even using the drugs the way you think the patient should use it? All right.
Shoot.
Are you getting my explanation, or you are just there
Yes.
chewing
Yes.
suya? Okay.
We are
All right.
getting it too.
We are getting it, Doc.
All right. So don't forget what we have mentioned. So brain natriuretic peptide, they will give you. It will be stated. The value will be quoted for you. Now come down to the treatment. I know you know treatment very well, because possibly some people, even as we are talking, still giving some patients, writing some plans for the patient on heart failure. But there is something I want you to take into the exam. It's not cramming. It's a concept. All right. So what is the concept? The concept is, you see the way they've put it here. When you see the heart failure, you check for the hemodynamic profile of that patient. Is this patient wet? You say the patient is wet if you are seeing all manner of congestions, picking crackles in the lungs, and all manner of stuff. You say the patient is dry if all those things are not there. You talk about warmth, which gives you an idea about perfusion. So if the patient is well perfused, you touch the patient, you check the patient, you realize the patient will be warm. If the patient is cool or cold, the perfusion is reduced. That's what it means. Now, when you get into this exam, you must remember that the drug you are going to give will address these two guys: perfusion and wetness. Perfusion and wetness. Now, which of them are you now going to focus on first? You now quickly, the small paper they will give you in the exam, just remember that Festus mentioned that I must focus on perfusion and wetness. But which one will I focus on first? If both of them are there, the one you focus on first is perfusion. You get to letter P before you go to letter W. Wetness is W. Perfusion and wet before wetness. Perfusion before wetness. So wetness is like congestion and the like. Perfusion before wetness. So this is now the trick you will be using to treat all your heart failure patients. You want to address the perfusion. If you realize that the perfusion is poor and the patient is also wet, it is the drug for perfusion you will pick as your answer. If you realize that the perfusion is normal and the patient is wet, then you go to wet because the perfusion is already okay. So ensure the perfusion is okay before you start looking for the wetness. Ensure the perfusion is okay before you start looking for the wetness. Ensure the perfusion. You can even relate it to the our day-to-day activity, the common word phenomena, and the likes. I don't want to be saying some stuff before you people will say that Festus, you are saying rubbish. Let me keep my mouth shut. But perfuse before wetness. Don't forget that. All right. How are you going to ensure perfusion? That will now be your question. So when you read that question, you will just check. Is this patient well perfused? Is this patient well perfused? If the patient is warm, the patient is well perfused. If the blood pressure is looking okay, the patient is likely well perfused. All right. So look at this. So let us go through them one by one now. If look at this this part of the table, this is wet, this is dry, this is warm, this is cold. All right. So if I focus on this quadrant here, it means the patient is wet and warm. The patient is wet and warm. Because the patient is warm here, I do not need to be focusing on what? Perfusion again. The patient is already well perfused. I will now focus on what? The wetness. Which drug am I going to use to reduce the wetness? I will now use diuretics. So just don't forget diuretics basically. Anyways, diuretics. Can you see? Diuretics. That will really help. Okay, basically that's that. If you come here to this quadrant, the patient is warm and dry. This is looking like normal patient. Where you are seated, you are warm and you are not wet. Can you see? Where I am seated, I am warm. I'm not wet. I'm normal. And this patient also has symptoms and signs of heart failure. Then this is chronic heart failure. Do you now stop treatment? No, you don't stop treatment. I've mentioned that before. You now optimize the oral therapy. You encourage the patient, continue taking your drug. You counsel the patient. You do all those are the things you will be doing here because the patient is neither congested nor poorly perfused. Now you come down to this next quadrant. You check the patient is wet and cold. Because the patient is wet and cold, I want to address the coldness before going to wetness. Can you see? So for me to address the coldness now, I will quickly check the you can quickly check the systolic blood pressure. That can help you, most especially if the patient is hypotensive. So what are you going to do? Inotropic agent. You give the patient so this drug will just help in the contractility of the heart. These drugs will help with the contractility of the heart, dobutamine and the likes. So these are the drugs you are going to give here. So that's that, inotropic agent to help with the perfusion. After that, after you've corrected this hypotension, the perfusion and the likes, you now give the patient diuretic. You now address wetness. Can you see? So when you get into the exam, you will have been hearing crackles everywhere. You now check the blood pressure or they tell you that the patient is cold. You are now like, diuretic. We know that is what you've been giving. Only God knows how many patients we've been able to injure in the name of poorly understood medical concepts. diuretic. And I say, okay, I saw that patient, I just gave this thing. God has been saving a lot of patients in our hands. The ones that we ignorantly just give drug because we think that's what the drug. The drug is supposed to just remove fluid, and that will help the patient. Yes, you just realize, we treated the patient, and the patient just did not really make it, and the condition was poor. Before they brought the patient, there was a delay and the likes. No, it's not that. Sometimes we just need to check ourselves and ask, are we actually doing the right thing? Yes, the patient is wet and cold when they brought the patient. So, what do you want to give first? Don't forget inotropic agent. Initially, you give that. Usually, again, when you realize that you are seeing evidence of poor perfusion, basically, you are seeing evidence of poor perfusion. But if at all you check, you realize that systolic blood pressure is already okay, which is what you are using to peep into the perfusion and the warmness or coldness of the extremities. You check the systolic blood pressure is already okay, more than 90. So you just take it like the perfusion is okay. Maybe the patient is not just having enough. He's just having the congestion actually masking whatsoever the patient is having. Then you just give the patient the diuretics. So look at the blood pressure when you get into the question. Is it less than 90? Is it more than 90? And the likes. So look at this one, dry and cold. Dry and cold. So the patient is already dry. So which means there is really no problem with wetness. But you can see the patient is cold, which is an evidence of poor perfusion. All right. So where are you going to start from? So usually in this regard, you start with fluid challenge. In this regard, you start with fluid challenge. How come you were not starting with fluid challenge in the others? Because the patient was wet. When you are giving fluid to someone that is already wet, you are going to complicate it. Can you help us mute your mics? So you are going to complicate it. Do you get it? That's why you are not giving fluid here. But here, you can initially consider fluid. If you realize that the perfusion is still poor, you now give the patient inotropic agent. And that is how you will be treating the. So if you now sit down here, you are like, you want to cram this, you will actually be cramming things that you will forget tomorrow. So what I will advise you to do basically is just to look at the simple way of looking at this and see if at all it helps you or it doesn't help you. Look at this question. They say 72-year-old man is admitted to the ICU with cardiogenic shock following an acute MI. His hemodynamic parameter given. Cardiac output is first of all low. So you're already saying that this cardiac output that is low. So what's going on? Pulmonary capillary wedge pressure, which gives you an idea of what is going on in the left part of the heart. You can see it's very high. So that shows that there is left heart failure so far now. Systemic vascular resistance is also very high, which is what you expect, sympathetic nervous system activation. All right, they now say which intervention is most appropriate to improve this patient's hemodynamic status. All right, so if you look here, so though this question is not really too correct the way you expect the question to come, because they will give you the other details that will enable you to characterize, is it wet, is it dry, is it this, is it that, and like you'll be able to characterize it very well. So let me even see if I can see any of such questions. So you use that one to okay. Let's look at this. I think we have more detail here. Okay, look at this one. 68-year-old man present with acute decompensated heart failure after an episode of acute MI. Vital signs, you see the blood pressure is low, the patient is hypertensive, heart rate is quite high, respiratory rate high, jugular venous distension, peripheral edema, bilateral crackles. So if you look here now, you are seeing crackles, you check the blood pressure, you can see it's low. So there is both hypoperfusion and wetness. All right, so you can see both hypoperfusion and wetness. They now ask you here, the cardiac output is giving, pulmonary capillary wedge pressure, just something to point towards heart failure here for you. Which of the following is the most appropriate initial management? So what do you think will be your answer here now?
Which code before what? Oh, lobotomy.
Lobotomy. All right, so let's see. That's correct. So that's how, if you look at it, they even put intravenous furosemide here. Do you get it? So someone that is not careful might want to quickly rush there and pick that. So that would be wrong. So let me allow us to okay, let's continue till for the next 30 minutes before you go for break. So acute congestive heart failure management, you don't need to cram this. You already know how to go about it anyways. Then let me say this: if you realize that the patient's SpO2 is low, you need to give oxygen. Don't forget that. If the SpO2 is very low, you need to give oxygen. Don't forget that. All right. These are just the drugs that you know, so I don't think I should bother you on that. And all these ones, you already know when you give inotropic agent, under which conditions. So all you want to pick here is just the name: milrinone, dobutamine, dopamine, and the like. So when you hear someone shouting dopamine, go and bring dopamine, don't say that Emma Pami now. So like there is a reason. You check and listen and be like, oh, this really makes sense. So that's how you look at it. So you don't need to sit down here and cram anything. No, you don't need to. Don't cram it. So just based on what I've explained, just look at the scenario they've given. What am I addressing? So this is what I'm addressing. Beta blocker is contraindicated if the patient is having decompensated heart failure. So please never forget that. So because all the symptoms are already failing. You also want to avoid morphine because they will reduce most of these system stuff the more. They will reduce them the more. Now look at the chronic heart failure. You already have an idea of what is happening in chronic heart failure. Do you get it? So the patient is usually symptom free, but you want to ensure that you maintain the patient on the therapy. So now this patient is coming to you. All the drugs you want to be giving basically just to reduce mortality. Basically, you just want to ensure that this patient suddenly does not die. If the heart rate is high, more than 70%, the patient may benefit from ivabradine. So you hardly see them test this anyways. So but just for you to note it. Low dose spironolactone, if the potassium is lower and the left ventricular ejection fraction is also less than 35, the patient can benefit from low dose spironolactone. So you are not bothered about all these things. Just remember the same drug, SAMe, that I've given you before. Just apply them here. SAMe that I've given you before. Those are the drugs that will reduce mortality in the patient. So you can place the patient on them. Do you get it? You can. So if at all you realize that the potassium is high, you want to be very careful prescribing low dose spironolactone for the patient. Do you get it? Because it's going to, you might want to make the potassium to rise the more. So you don't want that. You don't want to push the patient. So the patient can be on dapagliflozin. It's one of the, that's SGLT2 inhibitor. Do you get it? So that will help the patient. Do you get it? Beta blocker. Do you get it? Don't forget that. That will also help. ACE high and the likes. These are the drugs that will reduce. So when you see them in the question, I mean the question, you are not bothered. Like, hey, why are you placing the patient on this 4 set of drugs? SAMe. You know they are the drugs you use in heart failure with reduced ejection fraction to reduce mortality. However, for the heart failure with preserved ejection fraction, the only drug that reduces mortality is the SGLT2 inhibitor. So everybody is clapping for you. They are like, doctor, you did it. The patient is now better and the likes. But you can actually have some instances where the patient does not really improve that much. Now, we come down to what we call device therapy. You say, you sit the patient down. You are like, now we need to start looking at giving you a device. The next thing the patient will say is that, doctor, why? Where? I've spent a lot. I've done this. You need to explain. So you are not just prescribing them for fun. You are seeing something that you need to be able to pass the information across and place the patient on whichever device you want to place. Now let us go through this device so that when you are looking at the question, you are looking at the question with clarity of mind. We have three major devices that we put in the question. The first one is ICD, implantable cardioverter defibrillator. The next one is CRT, cardiac resynchronization therapy. The last one is this mechanical circulatory support, left ventricular assist device, LVAD. So these are the three they will put amidst the option. Under which condition do you now go for? The answer is ICD, the answer is CRT, the answer is LVAD. Let me explain them very well. What is the essence of ICD? Check it. It's a defibrillator, actually, implantable cardioverter defibrillator. So it shows that the patient is either at risk of arrhythmia or the patient has developed arrhythmia before. Think about it. The patient is either at risk of arrhythmia or the patient has developed arrhythmia before. That is when the patient needs to be on this. Wait, how will I know that this patient is at risk of arrhythmia? You now remember, I've told you before, anytime the heart dilates, the tendency for arrhythmia occurring is very high. Anytime the heart dilates, the tendency of arrhythmia occurring is very high. Now, if I am dealing with heart failure, which category of heart failure will the patient dilate, have the heart dilating? The heart failure with reduced ejection fraction. The heart failure with reduced ejection fraction. The patient is most likely going to develop arrhythmia. So if that is the case, I want the patient to be on ICD. Can you see the way you are looking at it? Under which condition? Does that mean all the patients are just placing them on ICD? No. I have seen that this patient has reduced ejection fraction at 40 days post-MI. 40 days post-MI and 3 months post-revascularization. The patient is at risk of later arrhythmia. Like what? Ventricular tachycardia, ventricular fibrillation. So once you see this and post-MI and this one, that one, and the likes, so the patient is at risk of developing arrhythmia. You want to prevent those arrhythmia from killing the patient. They will just occur suddenly and the patient will die. So the patient needs to be on ICD. So which means that when you are in the exam, you are reading that question, you are only checking for, is this patient at risk of developing arrhythmia? What kills most patients with MI is arrhythmia. What kills most patients with MI is arrhythmia. It's not really the pain, it's arrhythmia. Most especially within 24 hours. Arrhythmia. So you must look out for this. Symptomatic patients, you can see NYHA classification 2 and 3 with reduced ejection fraction at 40 days post-MI and 3 months post-revascularization. So you want to place them on ICD. All right, so don't forget this. You can use it as for primary prevention. You can also use that for secondary prevention. Primary prevention, I've talked about that. Secondary prevention, the patient had the arrhythmia before. The patient escaped the death. Now you must place the patient on ICD. That's what you check for. What about the CRT? CRT. I'm not going to bore you with unnecessary detail here. What you want to use this one to correct is what we call the ventricular desynchrony. Ventricular desynchrony. All right. So you just see this abnormal ventricular contraction that will reduce cardiac output. Do you get it? So you want to correct that. What you use to correct that is cardiac resynchronization therapy, CRT. All right. What will I now check for? For me to say, I'm going for CRT. I'm going for CRT. First of all, you will say left ventricular ejection fraction will be reduced to sinus rhythm will be here, which means that you are not really dealing with all these abnormal arrhythmia and the likes and the likes. But there is something you will see here that will help you out. You will see something that's related to left bundle branch block with QRS of at least 150. That's more or less like widened QRS. Widened QRS. So please don't forget that. So you will see this left bundle branch block with a QRS of at least 150 milliseconds. So this is all you are going to look out for that will help you. And the patient must have been on optimal heart failure therapy, and that is no longer helping the patient. The question now says the patient is developing a left bundle branch block. This is someone with heart failure. And that's what do you want to do? Your answer will be CRT. That's your answer. What about the left ventricular assist device? So left ventricular assist device. So usually give this one to the patient if you realize that the how do I put it? The circulatory support is not adequate, or the ICD, the CRT devices are failed. These first two have failed the patient. You just want to support the heart. Let us support you to be maintaining your pumping activity. That's LVAD. All right. All the patients is already having something like end stage. How do I put it? End stage cardiac failure, heart failure, something like that. So you can place the patient on LVAD and the likes. All right. So that's just by the way, just to maintain the circulatory function of the heart. ICD has failed, CRT has failed, then the patient can benefit from this. All right. So let me show you just like a question or so, just for you to have an idea of how you look at this. 68-year-old man with history of ischemic cardiomyopathy. You say, okay, present for follow-up. He has dyspnea on exertion and lower extremity edema despite optimal medical therapy. They will have been given all those drugs we talked about, but you can't really see much, including beta blocker. ACE high and diuretic. His echo shows left ventricular ejection fraction of 25. A 12 lead ECG shows a left bundle branch block, and a QRS duration of 160 milliseconds. So immediately you see that this is a patient with heart failure that is first of all on optimal medical therapy, and I'm still seeing left bundle branch block. I'm seeing QRS complaint that is very wide, more than at least 150. So which of the following is the most appropriate next step? Your answer will now be CRT. So I want you to look at this next question and pick your answer for me. 55-year-old woman with non-ischemic dilated cardiomyopathy, left ventricular ejection fraction of 30. She denies syncope, chest pain, palpitations, is on optimal medical therapy, including a beta blocker. So you realize that even the left ventricular ejection fraction is not improving. And angiotensin receptor neprilysin inhibitor, the patient is on that too. They now say ECG shows sinus rhythm with a QRS duration of 90. Which of the following is the most appropriate recommendation? You will just be like, wait, we are placing this patient on all the medications, optimal one. The thing is, left ventricular ejection fraction is not improving. You check, go and do ECG for me. Why did you ask the patient, oh, you're going to repeat the ECG? You want to rule out left bundle branch block. Look at the QRS duration. You check them. They check all those stuff. They are not looking too bad. Is there any other thing? And the relatives are sitting beside the patient shouting, doctor, what next? Doctor, what next? You now say, left ventricular ejection fraction is reduced. We've given all the drugs. This patient is at risk of death. From what? They say, from what? You say arrhythmia. Why? Why arrhythmia? Are we not already giving all manner of drugs? Because the ventricles are still dilated badly. All right. So in this regard, you need to place this patient on something to prevent sudden cardiac death. From what? Ventricular tachycardia or ventricular fibrillation. And the answer will now be what? Implantable cardioverter defibrillator. That's B. And that's how you'll be looking at the question and just check. What have you done? What have I done? What is this patient at risk of? Have you done ECG? They say we've done it. Can I see left bundle branch block? They say yes. Then CRT. Can I see left bundle branch block? They say no. Yeah, then you'll be going for something like ICD. Now look at this. No, question 4. 74-year-old man with end-stage heart failure. The patient is already at end stage. Refractory to optimal medical therapy. He's being evaluated for advanced therapy. He has severe dyspnea at rest. Frequent hospitalization. Every 2 hours, they are bringing the patient to the hospital. In fact, all the nurses, they are tired. They are like, what's going on? Severe dyspnea. His left ventricular ejection fraction 15. They are counseling the patient. Let's do cardiac transplant for you. And you assess the patient. The patient is not a candidate for cardiac transplantation due to all manner of comorbidities. The relative look at you, look at themselves, look up to the sky, look down, look back at you and say, doctor, what next? You look up, you look down, you shake your head, you nod it at the same time, and you say, since this patient is not a good candidate for cardiac transplant, the only thing that is left for us to do is just to support the heart. And at this level, your answer will be left ventricular assist device. So you just want to support and see what, just to help the patient manage the symptoms and the likes. And that's how you will be looking at this device therapy in the exam. Are we getting it or we are not? All right.
Yeah. Yeah, sir.
Okay, lovely. So let me allow us all to go for break. So you can go for like 8 minutes break. We come back, then we nail it. All right. Thank you so much, everyone. All right. So I will continue from where we stopped. So now you come down to this area, digoxin, which is one of the drugs you can actually use to increase the contractility of the heart. All right. So now there are 2 things you should expect them to test you on in the exam here. So just 2. One of them is what we call the digoxin effect. The second one is what we call the digoxin toxicity. Can you see? Digoxin effect, digoxin toxicity, digoxin effect, digoxin toxicity. So you must be able to, from step 1, you already know how digoxin acts. It's a sodium-potassium channel blocker. But let me quickly make an illustration for you so that you get the idea here. So let's also assume that this is sodium potassium. So channel. So this is potassium. This is digoxin. So both of them can actually bind to these binding sites. Can you see? So what it means is that anytime, so this is digoxin, this is potassium. So anytime the level of potassium is low, more digoxin will be binding. So the patient is most likely going to be at risk of digoxin toxicity. So what that means is that in the exam, that would be where they will now go and hide. They will just tell you this patient has been on digoxin, it's placed on digoxin, and the potassium level is this. They will just give you the value. You will now be the one to determine whether it's low or normal. So if it is low, they will now ask you that which of the following is this patient at risk of? The answer will be drug toxicity. Do you see the way you nail that? You just look and be like, oh, this is most likely going to be drug toxicity or digoxin toxicity. So if the potassium is low, more of digoxin will be binding. Now, what about the potassium level is high and you are giving the patient digoxin? You won't really see the effect of digoxin as such. You won't really, because most of the potassium will be the one binding, while the digoxin will not really bind. Do you see? So that's how you look at it. So low potassium increases digoxin binding, leading to toxicity. In a patient taking digoxin, always check the level of potassium, always check the level of magnesium, always check the renal function. So if the potassium is very low, the patient is at risk of toxicity. If the potassium is very high, you won't really see most of the effect of digoxin. Now, next question is, what will I see in the question that will give me an idea that this is the digoxin toxicity in display? What will I see? You see, they will just tell you that this patient is having some symptoms, and you realize that the patient is maybe having some stuff related to GI. You may even be having diarrhea, abdominal pain, and the likes. Might be having some neurologic symptoms. Might be seeing some flashes. Might be seeing some colors. So look at this. The patient is having abdominal pains, nausea, vomiting, anorexia, that's for GI. Neurologic symptoms can come in the name of confusion, having weakness, fatigue, color vision, yellow green. You'll just be seeing all those stuffs. Then the patient can have arrhythmia, life-threatening arrhythmia. And anytime you hear the word life-threatening arrhythmia, so it can actually be any of those life-threatening arrhythmia, ventricular fibrillation, tachycardia, and the likes. So these are the things you will see. And they will also mention that the patient is on drug. All right. So another thing again they will do is to give you this ECG. What you will see in the ECG is what we call the atrial tachycardia with AV block. Atrial tachycardia with AV block. So you can see all these red arrows, they are the atria actually contracting, atrial contraction. You can see P wave. All this time that P wave is actually being generated, you do not see any QRS complex, which should reflect ventricular contraction. You do not see that. All right, so which means that there is a delay at the level of heavy block. Then you now see the QRS complex being generated. So because for every P wave that is generated, you are supposed to see a QRS complex to follow it. But how come you are seeing P wave, then later you now see a QRS complex being generated? So what happened to all those P waves that QRS complex do not follow? So most likely you are having AV block. All right, so that's that here. You can see the QRS. You can see just a P wave. But you won't just look at this ECG and just start beating your chest, biting your fingers, and be saying that, oh, this is digoxin toxicity. They will tell you that the patient is actually on digoxin or something like that. All right, that's for digoxin toxicity. So another thing again you see here is I know that, okay, maybe you check the options, you are seeing toxicity effect. Am I dealing with digoxin toxicity and dealing with digoxin effect? You can actually come to this ECG and draw a letter T here. You can come here and just draw a letter T here. So you know this is most likely the one for toxicity. What about the one for digoxin effect? So with respect to the digoxin effect, what you will see is that you want to know whether the digoxin is even working or not. You want to know, is this digoxin working? You want to say. So what you will see is the patient has been on digoxin. They will actually want you to think like the patient is already developing toxicity. That's what they want you to make. They want you to think about. But they want to test. Do you even know what you are looking for? That's why they will now test this one for digoxin effect. Do you get it? They will give you, this patient has been on digoxin, they will now give you the ECG. You will now see this on it. They will not give you any symptoms anyways. So you now see something like this. You call it downsloping ST depression. You can see downsloping S3 depression. So you see this here. So when you see this, it means that the digoxin is actually working. It's active. It's doing what you want it to do. So don't go and unnecessarily increase the dose. The patient is already fine. That is for this ECG. So try to remind yourself the two ECG. This one will look normal except for the downsloping ST depression. Whereas for this one, you will see something that look like this. You see multiple atrial contraction in the name of P waves. Then you now see occasional KRS complex being generated. There are some drugs that can actually precipitate digoxin toxicity. So they will tell you that the patient is taking those drugs, one of those drugs, together with digoxin, amiodarone, beta blocker, verapamil, macrolide, amphotericin B, and the likes. So they can precipitate digoxin toxicity. So look at this. 68-year-old man comes to the clinic due to palpitations that have been especially prominent over the past 2 days. You're like, what's going on? Why you have all manner of stuff going through your mind? Medical history is significant for myocardial infarction, heart failure with reduced ejection fraction. You are just nodding your head. And now the medication that this patient has been on include aspirin, digoxin, furosemide, sacubitril, fasatine, metoprolol, and atorvastatin. You just look at the drug, because you are taking the drug history, or you look at the chart of the medication the patient has been on. To be very sincere, you don't know what is going on in this patient. All you can see is that despite being on beta blocker, despite being on having all this, the patient is still having, is having palpitation, which is pointing towards something like arrhythmia. But you don't know. You now say physical examination reveal no murmur or extra heart block. Heart sound. The lungs are clear to auscultation, no peripheral edema. ECG shows atrial tachycardia with second-degree AV block. Immediately you see that there is atrial tachycardia, and this patient has been on digoxin amidst all the other drugs. So you already know that this patient is likely having digoxin toxicity. So what could have precipitated digoxin toxicity in this patient? You now go through the drug again, because that's the only thing you can go through. So if you find yourself in a place where you don't even know what is, you can't remember the drug, just say your answer will now be digoxin toxicity secondary to drug-drug interaction. That's how you put it. Digoxin toxicity secondary to drug-drug interaction. And if you can specifically nail it on a particular drug, you just say, okay, maybe from this metoprolol, which is a beta blocker. And that's how you'll be looking at. You can also flip through this. So I don't want to waste your time. So let me just pause it a bit. You can take the picture, so you can flip through it. All right. So these are the other options. So you can check that. All right. So that's just by the way. Look here at failure now. With preset, you can see how we've gone through the one for reduced ejection fraction. So, and that's that. Now, we want to flip through the basic points you want to take into the exam with respect to heart failure with preserved ejection fraction. What are those things that should make sense to you? So, the number one, the first point is, when you check the question, you will see something related to heart failure. You will now see, they will quote the value of ejection fraction for you, now see that it's 50 and above. So that's when you know that this heart failure with preserved ejection fraction. And don't forget, the patient is most likely going to be of age 65 and above and the likes. All right. So and don't forget, your main treatment will be towards comorbidity. What are those things this patient is still having that I need to address? If the patient is obese, your answer will be advise the patient to cut down the weight. That will improve the patient drastically. So if the patient is having maybe whatsoever the patient is having, just address it. How do you make the diagnosis again? Best initial test that I told you they will ask you, echo. Don't forget. And now, let me be specific on the echo now. The echo you do is transthoracic echo. There are two forms of them. You have the transesophageal, you have the transthoracic. It's just on rare occasions that you see them saying you should go and do transesophageal. Echo is echo, transthoracic. You just put the probe on the chest and check the heart. That's transthoracic. Before you start telling the patient to open his mouth and start passing it through the esophagus. Do you get it? So transthoracic is what you go for. So when you get into the exam and you are saying transesophageal, be very careful. Be very careful. It doesn't mean there are not instances where you go for transesophageal, but transthoracic will do the justice here. Then with respect to the lab, just like the reduced ejection fraction, here natural erected peptide, it will be elevated. Although 20% of patients may have their own normal. You see, this 20% of patients having their own normal will not be given in the exam. So you will just be seeing the natural erected peptide being high. Don't forget that. So what is the treatment you want to give to this patient? Symptoms relief, comorbidity address, then place the patient on what do we call it? SGLT2 inhibitor to reduce mortality. So if you look at the heart failure with reduced ejection fraction, there are 4 sets of drugs there that can reduce the mortality, whereas here it's only 1 set of drug, and this is the one they will test in the exam. They love to test this drug like water because it's the only one. So when you are seeing the patient, they don't even want you to be thinking about any other thing. They just want you to think about, just say it. They don't even want you to think at all. Just say it and be like, it's just SGLT2 inhibitor that will reduce mortality in heart failure with preserved ejection fraction. Bam. That's what they need. So like, expect this question. It's not out of, like, that's the point. Expect it. All right, all these digosins, spironolactone, and all those drugs that you see in heart failures with reduced ejection fraction, they are hardly indicated in preserved ejection fraction. You can see the peculiarity, and that's why you need to understand the point we've been trying to make. And that is the end of heart failure here. Now, I want to take you through a specific cause of heart failure now. Cardiomyopathy. So cardiomyopathy can be a specific cause of heart failure. So the cardiomyopathy just means that there is a pathology or something going on in the heart muscle. That's cardiomyopathy. All right. So we don't know where it's coming from. Is it secondary to something, or is it just primarily due to maybe a genetic mutation or something? But something is going on within the heart muscle that is making the heart to appear big, that is making the heart muscle to look thick, or to just be dilating unnecessarily. So we have three types of them: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. Don't feel bored. I will be very specific on what you are expecting in the exam and be like, okay, this is what they are most likely going to test. So don't be carried away by the names and all those jargons. So now, where your confusion is most likely going to start from is you separating hypertrophic from restrictive. You see, for the hypertrophic and restrictive, the left ventricular cavity size is reduced. Dilated one, you will see the cavity, left ventricular cavity size will be very large. That one, first of all, even point towards dilated for you. So that's if I thought they give you the echo. You just check the left ventricular cavity size. You just see it and be like, wow, this is quite big. Then left ventricular cavity size. Okay, we've already mentioned this. During systole, during diastole, the same picture. Ejection fraction is going to be reduced in dilated. That's why it's dilating. It's not really pumping it out. Hypertrophic ejection fraction will be normal or high. In restrictive is also normal. So if you look at the restrictive and hypertrophic, they look alike. Do you get it? They really look alike. So there are some things you pay attention to in the question that will help you to know that this makes sense. To separate them, I will show you. So let's come to the dilated cardiomyopathy. You must never forget what I want to mention here. You already know what you will see that will make you to think towards dilated. Now, the way the question usually comes is that they will lay down a premise. they will lay down a premise. They will just ask you that what's the diagnosis. So if you understand the premise, you can easily just go and pick dilated straight up. You're already seeing symptoms and signs of heart failure. They lay down, they mention this, mention that, and the patient is this, is that. You just ask you what's the diagnosis. You just be like dilated cardiomyopathy. So there will be something affecting the heart muscle in that question. So what are those things? It can be idiopathic or genetic. It can also be secondary or acquired. So for the secondary one, that is very common. And usually they love to test these guys. It doesn't mean they can test the other. I will still mention the other. Alcohol. So someone that is taking a lot of alcohol, so that's having alcohol use disorder. So that patient, they can just tell you that, they just list all the symptoms and the like, but they will have mentioned that this patient used to take a lot of alcohol. They now say that what is the diagnosis? So dilated. You see, you have more causes, secondary causes of dilated than the hypertrophic. You have more secondary causes of dilated compared to hypertrophic. So you can read the question and just assume, even if you don't know, and just say this is dilated, more dilated, oh, dilated, that's dilated. So you can make that kind of rule. You don't need to be afraid to get something wrong. So you just look at it and be like, I can see a premise here. Why the hypertrophic is more of genetics than something causing it. It doesn't mean that you can have some secondary causes there too. But this one for the dilated is more actually of acquired than genetic. So if I read the question, I'm seeing alcohol, this patient has been taking a lot of alcohol, this patient is obese, this patient is this patient is that, and all manner of stuff, and the like. So I'm most likely going to be thinking more towards dilated than hypertrophic or restrictive. So they love to ask around the alcohol. Another one you should expect is post-viral myocarditis. Now, this post-viral myocarditis so far, help us to mute your mic, Dr. Uche. Thank you. All right, so far now, it is this post-viral myocarditis they usually test in the exam. So far now, it is this post-viral myocarditis. So the way the question will be is more or less like maybe so year old recently had a viral infection or something, or upper respiratory tract infection and the likes. Now develop symptoms and signs you can peg on heart failure. Viral infection, this heart failure. They now ask you, what do you think is going on? You'll be thinking towards something like dilated cardiomyopathy. Can you see how specific I am? Another one that they've also tested recently is about this drug, doxorubicin. Do you get it? Doxorubicin. They just tell you that the patient is on one. They can mention the specific name of the drug, or they just say they are treating the patient for this also condition, and the patient is placed on this drug and like. Just be like, okay, just don't forget this doxorubicin is a very well tested drug in the exam. Then sidofudin, this is antiviral. Now cocaine is another one where the patient is most likely going to be a young experimenting drugs here and there. So that's the radiation, maybe someone with breast cancer that had a radiation therapy, that may be, but it's not something that is commonly tested. But note it, you will just be seeing all those premises there. Chagas disease is not bad. I mean, it's not something you don't know. Chagas disease from trypanosoma infection, nutritional deficiency, that is beriberi, thiamine and the likes. So these are the things you are expecting them to test in the exam. But don't forget this alcohol and post-viral. Wet beriberi, Chagas, just as I've noted them. If at all you go through your question bank and you see some other stuff, note them. But you usually see the thing is secondary to something for dilated. And the other things we've talked about, you see them playing out, the kind of heart sound you hear and the likes. How do you make the diagnosis too? Echo, the same thing that we've been emphasizing. So chest X-ray, what will you see? Enlarged. It will be enlarged and the point of maximum impulse will be displayed. So how do you want to treat? So usually don't forget, because now this is cardiomyopathy causing the heart failure. Don't forget to address the cause, because you can treat all the heart failure all you can and the likes, but you even fail to address the underlying cause, etiology. So the patient will still come back again, most especially if the underlying etiology is still there. So that's one thing they want you to note. What about the hypertrophic cardiomyopathy? So usually you can link genetics to this one. So it doesn't mean that there is no one or two other thing that can cause it. So usually, if I will summarize this for you, I will just say when you get into the exam and you check the patient is having heart failure, but you can't really see something precipitating it and the likes, or something you can peg on, this is what is causing it in the question, most likely you are dealing with hypertrophic cardiomyopathy. If at all you want to peg it on something, so you can look at it and be like hypertrophic cardiomyopathy. But there are still some other ways of knowing whether it's hypertrophic cardiomyopathy. Family history of sudden cardiac death, do you get it in the question, and the likes. So that will also give it out. So but you hardly see most of all these the patient has a viral infection, now develop this. No, that's not hypertrophic, that is dilated. The patient has that one, dilated. This also infection, dilated. That one, dilated. Radiation, dilated. You just keep naming them. That's most likely going to be dilated one. But for hypertrophic, usually from these genetic conditions, rather. There is a form of hypertrophy that you must be aware of that we've talked about before. You call it HOCM, HOCM, hypertrophic obstructive cardiomyopathy. And it is the most common cause of sudden death in young, healthy athletes in the United States. Are you coming to the United States? Yes. Do I need to know it? Yes. Can't I just forget it? No. Because you are going to see a lot of people. You may see a lot of people with this, and if you do not know, it's going to be a very big slap on the face. It doesn't mean you won't still know it if at all you don't know it now. It's just that it might be in a way embarrassing that you can't even say that this is likely to be HOCM, because the history will give it out. Family history of sudden cardiac death, or the patient developing arrhythmia during exercise, or developing lapsing into unconsciousness during exercise and the likes. So when you see that, you'll be like, are you sure we are not dealing with HOCM? Just the same way you've mastered it. The next thing is about those maneuvers we talked about. The next thing is about what? Those maneuvers we talked about. So you now pay attention to them when what will happen to the murmur in them when there is increase in preload. Do you get it? What will happen to murmur in them when there is reduction in the preload? So when there is increase in preload, you realize that the murmur in them is going to reduce in intensity. I told you about the arrows going in opposite direction. When the murmur in them is reduced, the intensity of when the preload is reduced, the intensity of the murmur in them will rise. So just be checking for the arrow. Are they going in opposite direction? So if the afterload is high, too, the murmur in them will reduce. If the afterload is low, the murmur in them will increase. Just check for those arrows going up and down. They are not going in the same direction like the other forms of murmur. So don't forget that. That will give it out. All right. Can you see? Just don't forget. You can see this. See this arrow up, down, up. Down, up, and the likes. So anything that is going to reduce preload in them, because if at all you are reducing preload, the obstruction is going to be marked. It's going to be more prominent, and the murmur will be more. So you don't want the patient to take any drug that will reduce preload. So what are these drugs? Diuretic. You just say it's contraindicated. Dehydration. You don't want the patient to be dehydrated. Hydralazine, digoxin, and the like. So you just need to be very careful. What about the point of maximum impulse? It's usually going to be sustained because the heart is not big. It's not that the heart there is no cardiomegaly, so don't forget that. So what is the best initial test again? Echo. Just the same way you have mastered it. And what will you see? Now, you need to be very careful here. What you are going to see depends on what you are dealing with. If you are dealing with hypertrophic cardiomyopathy, you can see symmetrical, hypertrophied heart walls. But if you are dealing with Ocum, you can see asymmetrical, hypertrophied heart wall, where you see more of hypertrophy at the septum, interventricular septum, more compared to the other walls of the heart. Do you get it? So that is how you identify Ocum. So they will just give you the image of the heart like this, and they will just show you that the interventricular septum is very, very big and it's not symmetrical. Maybe the upper part is bigger, thicker compared to the middle, compared to the lower in terms of the interventricular septum. Do you get it? That's when you know that you are most likely dealing with Ocum. So it's never going to be like this. It's never going to be like this. This is not Ocum. So this is Ocum. Don't forget. All right. So basically, that's that. And there is also one more thing you may see in them. You call it dynamic obstruction of blood flow, which is due to systolic anterior motion, SAM. You will have seen this a lot in step 1 of the mitral valve. Against what? Against the hypertrophied septum. So look at this sentence. You will understand. It is during systole. During systole, you see that the mitral valve will now move closer to this hypertrophied wall. If it's moving closer to this hypertrophied interventricular septum, it's going to cause obstruction. The blood will not be able to flow out through the aorta. It won't really be able to flow out through the aorta. So because you are now having the mitral valve during systole, when the blood should flow out, is now moving closer to this interventricular septum and causing obstruction. Can you see? So that's another thing you must note about it. So echo will show all those stuff because you'll be able to see it. Now, Festus, you've talked about so many things. Now, first aid people just came down to this list, and the next thing we are seeing them doing is writing about athlete heart. United States is a place where you see a lot of athletic activity, just like United Kingdom. So, which means that some people will come with their heart being big. You will see left ventricular hypertrophy, and that's what I mean, left ventricular hypertrophy. Before you start shouting, hypertrophic cardiomyopathy, how don't you see? Don't you see? No. The USMLE step 2 will now specifically ask you, what will you look out for? What will you look out for? I don't want you to cram anything. Just think about it. Think about it. Hypertrophied cardiomyopathy or hypertrophic cardiomyopathy is a cardiomyopathy, is a pathology. If it is a pathology, what it means is that there are some things that will be going on in the heart that are not physiologically normal. There will be some stuff going through the heart that are not physiologically normal. All right. There will be some stuff going on in the heart that are not physiologically normal. For instance, you are not supposed to see something like left atrial enlargement in athlete heart, because in athlete heart, whatsoever that is going on there is physiologically normal. Think about it. Whatsoever going on in the athlete heart is physiologically normal. Most of the things going on in the hypertrophic cardiomyopathy, they are not physiologically normal. So, where are you going to start looking for stuff? You can check the the echo results. Check the left atrium. The left atrium in athlete heart will be normal because the heart is just big because of the exercise and the light that the patient has been doing. But hypertrophic cardiomyopathy, the left atrium will be enlarged. Why? There is outflow of the blood limitation. Because of that, there will be a lot of stasis going on, and because of that, blood from the left atrium cannot really empty completely into the left ventricle. And the next thing you see is that over time, the left atrium will start enlarging. However, that is not going to be seen in the athlete's heart. All right. The left ventricle cavity size is reduced. Yeah, it can also be reduced in a way in athlete heart and the likes. Left ventricular thickness, yes, is thick in the ACM. It's also going to be thick in the athlete heart. However, the thickness in athlete heart is not pathologically excessive, whereas the thickness in ACM patients is pathologically excessive. So they usually peg it on 15 mm. So in ACM it will be more than 15 mm, while in athlete it will be less than 15 mm. So if you can just remember the fact that one is physiological, the other one is pathological, you don't expect differential dilation of the ventricles in the athlete heart, whereas you expect differential dilation of the chambers in the hypertrophic cardiomyopathy. All right. So that's that. Now, how do you now treat the hypertrophic cardiomyopathy? You see, this is highly important. Highly important. The best drug you must never forget, the best drug you must never forget in them is beta blocker. Beta blocker will block a lot of things in them, because what kills them most of the time is arrhythmia. A patient with OCUM, a patient with ACM and the likes, what kills them most of the time is arrhythmia. So if arrhythmia is the cause of their death, what it means is that if I can actually reduce the arrhythmia in them, that should actually, or abnormal conduction in them, that should actually reduce the tendency of sudden cardiac death. So best initial treatment when you see that in question will be beta blocker. Do you get it? So never forget this. You need to be very careful for the other stuff, diuretic, nitrate, keep naming them, using them. You need to be very, very careful. Diuretic may help ACM, but it's going to definitely worsen OCUM. So you know the maneuver we talked about, preload and the like. So don't forget that. Implantable defibrillator, don't forget, because of the arrhythmia. So because of the arrhythmia, so don't forget that too. And if it's that bad, you've used drug, the patient is not helping the patient and the like, you can go and use surgical septal myomectomy. So that may help. Is this the only form of hypertrophic cardiomyopathy question that we are expecting? No. There's also one more you want to put at the back of your mind, most especially for those that are going into pediatrics. Infants that is born or to mothers with diabetes, they have their entire body actually being big, including the heart. So because the heart can also be big, as a result of high level of insulin they are exposed to, what that means is that when they are born and the insulin level drops, do you get it? The thing should in a way go back to normal. But you just see that the heart of this patient is big. There is a diagnosis of hypertrophic cardiomyopathy. So what are you now going to do? They come to you. The mother is shouting, "Doctor, they have made the diagnosis. We saw it. Doctor, this is the result." And you are like, no, I've seen the result on the screen. They've sent it to me too. The husband looks at you and the husband is like, "Doctor, I don't want anything to happen to my child." The mother looks at you and be like, "I'm still having the pain of the labor." And you look at them, nod your head. The only thing that could open in your head is the first aid you have read. As they were talking, they thought you were listening, but you were opening the pages of the book in your head. And you are nodding, shaking. When you nod your head, you are like, "I can see it in my head." You shake your head. They thought you are shaking your head today. You are like, "I've still not found it." Oh, you can eventually see it. You now ask, you check the patient. If the patient is asymptomatic, usually it resolves. Do you get it? results. But if at all the child is symptomatic, so you can still give fluid and place the patient on beta blocker. Can you see? So if the patient is symptomatic now, give the patient IV fluid. Do you get it? That will help, and place the patient on beta blocker. If the patient is not symptomatic, so you don't really need to, you can place the patient therapeutically on beta blocker in a way, just low dose, just to help the child. But other than that, you see, they now ask you for how long will this patient, with our child, use the drug. You just say, okay, let's watch till around the age of 1, because we expect it to resolve gradually, and that's just the main thing. So this is just one of the things you want to note. There is a condition that looks like that can also cause what we call the sudden cardiac death. This one was also tested, and I want you to note it. That can also cause sudden cardiac death in the patient. You call it arrhythmogenic right ventricular dysplasia. The first time I will be saying this diagnosis was during my housemanship. There was a guy that used to move stuff. I don't know where he was getting all those. Not a house officer. I think the person was a medical officer anyway. So I don't know where the person was getting all this stuff from. And we just be moving the stuff and be like, yeah, it could also be arrhythmogenic right ventricular dysplasia. That was the first time I saw that stuff. So, but there is something quite peculiar about this diagnosis that you must note. Now, what is that thing? Number one, this has to do with the right ventricle. That's number one. From the name, you have an idea. The myocytes, what you see is that they are replaced with fatty or fibrofatty tissue. So the myocytes are replaced with fibrofatty tissue. So, but you don't forget that, because this is just a fatty tissue, the next thing you see is abnormal right ventricular dilation. Abnormal right ventricular dilation. Festus, did you tell us that anytime there is dilation, there is a risk of arrhythmia? You say yes. Now, the patient now lapses into the state of developing arrhythmia anyhow. And that is why you call that arrhythmogenic right ventricular dysplasia. The dysplasia first of all occur before arrhythmia becomes before the tendency of arrhythmia generation becomes very high. So you see, myocytes will replace. So what they will do is that they will tell you, they can give you an instance where you have the myocytes being replaced by fibrofatty tissue and the likes, and the patient eventually die. What can kill the patient is also sudden cardiac death. So if you look here, you can see sudden cardiac death here. You can also have sudden cardiac death in ACM, which OCM. So, but sudden cardiac death here is the second most common cause of sudden cardiac death in young patients. So when you see a young patient with sudden cardiac death, you can be dealing with something related to hypertrophic cardiomyopathy, or you are dealing with arrhythmogenic right ventricular dysplasia. So you don't know which one, and it's actually the arrhythmia that kills them in both of them. It's the arrhythmia that can kill them in both of them. Don't forget, it's the arrhythmia that can kill them in both of them. All right, so please don't forget. So when you now do biopsy, sorry, when you do echo, I wanted to say you'll be able to see that no, this is not ACM. Oh, this is arrhythmogenic right ventricular dysplasia that I'm dealing with here. When you do ECG for them, what you will see is what we call the epsilon wave. You can see that. You might not even see anything, but ECG shows inverted T wave. You can see the inverted T wave. So in feet 1, feet 2 with epsilon wave, this is the epsilon wave. So you can go and check this more. How do you treat? Just like the other one too. Suppression of the arrhythmia by placing the patient on beta blocker. Tell the patient to avoid physical exercise or activity. Do you get it? So this will help the patient. So I put an arrow on beta blocker, just like the way you look at the ACM. That will help. Let me show you just like something that might just integrate things together for you. 24-year-old male present with episode of syncope during exercise. His father died suddenly at age 40. EKG T wave is showing T wave infarction in lead V1, V2, V3. Epsilon wave. Cardiac MRI reveal fatty infiltration of the right ventricular wall. What is the most likely diagnosis? Your answer will now be arrhythmogenic right ventricular dysplasia. So you can go and check for more questions as you think. What about the restrictive? I've told you something about restrictive cardiomyopathy. It looks like hypertrophic cardiomyopathy. Now, I now need you to be relaxed and get the gist here, because this list looks wordy, but I will simplify it for you so that you have an idea of what you are looking out for. Remember the way the dilated looks, the way the hypertrophic looks. Dilated, you'll be seeing something that we shall press it, they will put it there. Infection, alcohol, radiation, keep naming them. For the hypertrophic, usually you might not really see much of what is causing it. But if most of the symptoms we are seeing will be related to the heart. Now, with respect to the restrictive, you need to be very careful, because you might see manifestation beyond the heart. That is one of the things you must look out for. You are most likely going to see the manifestation beyond the heart. Am I alone or we are together? Are you getting it? Or you have slept?
Yes, doctor.
Or you've slept off?
We're getting it.
Okay.
Yeah, very cool.
All right. And because sometimes some people, if you ask everyone to unmute their mics, in the next 10 minutes, some people will be snoring. Stop. All right. So what will help you out in the exam is manifestation beyond the heart. Now let's start with what we call cardiac amyloidosis. There is no doubt that you don't know amyloidosis. Just abnormal deposition of amyloid fibril around the body. If we now say cardiac amyloidosis, we are focusing on the heart here. Do you get it? Now, there are two wonderful types that I want you to put at the back of your mind. So the first one is this ATTR amyloidosis. Usually this is related to aging, people that are old. So when you check the question, this patient is most likely going to be old patient, most likely. We have another one that is light chain amyloidosis. Usually this is secondary to plasma cell dyscrasia, multiple myeloma. So what that means is that there will be a premise of multiple myeloma here. They will not mention that the patient has multiple myeloma. But when you look at the question, you are seeing something related to multiple myeloma in summary, and you know all the manifestation of multiple myeloma. Is it the abnormal production of the immunoglobulin? Keep naming all those stuffs affecting the kidney, this one, that one, and the likes. So you see that hypercalcemia, keep naming them. You may see that in question, and you will now see something that is related to heart failure. You see, I told you something about heart failure. Heart failure is just the constellation of symptoms, which means when you look at it, you can't look at that question and say the patient has heart failure. You are a joker. In fact, you are a comedian. No, it's not just heart failure. What is causing it? You now check. Can you see the manifestation in any other organ? Oh, I can see some eye, ear, oh, kidney, oh, liver, oh, that one. When you see that, you see this is most likely restrictive cardiomyopathy. Can you see the way you arrive at restrictive? Most likely restrictive, but you don't know which of the causes of restrictive cardiomyopathy you are dealing with. So for the cardiac amyloidosis, you will see something that's related to abnormal deposition of amyloid tissue. It's either the patient is of age or the patient is having multiple myeloma. All right. What are the other manifestations you will see there? You call them extracardiac manifestation of amyloidosis. You will now see them put proteinuria. proteinuria, hepatomegaly, macroglossia, bruising. Festus, do I need to cram them knee? No, don't cram them. But remember one. No, two. Two. Those two most likely going to be in the question. Proteinuria. 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 Macroglossia or bruising. When the patient, they might even say when the patient brushes the teeth, the patient bleeds and all manner of stuff. That's just that. All right. So that's about the how you arrive at cardiac amyloidosis. So they will just give you the question and ask you to diagnose. So that's by the way. Beyond that, they can also just likely to test you on this one, how you arrive at the diagnosis again. So you need to do investigation to justify cardiac and extracardiac manifestation. So for the cardiac manifestation, you are seeing left ventricular wall thickness. Don't forget restrictive. Then for the extracardiac, you are seeing proteinuria. You just do renal function test and you are seeing proteinuria and the likes. Liver function test, you are seeing deranged liver enzymes and the likes. There is something we call, because when you see the heart muscle being increased, you call that hypertrophy. You don't know whether it's restrictive. So the electrical impulse, the amplitude you usually get in ECG will be high. The thing will be very tall. That wave will be very tall if the heart is thick. You expect it to be very tall if the heart is thick. My heart is not thick, presumably by God's grace. Your heart is not thick, presumably by God's grace. If we do our own ECG, you look at the QRS complex, you check the amplitude, which is the height. Let us assume that it's just permit me, I'm just using arbitrary stuff. Let us put it at the level of 10 millimeter. 10 millimeter. So you look at the 10 millimeter and you are like, okay, that's fine. You now check another patient that the heart is thick. That one can go to like 20 millimeter. That the heart is thick, because the bigger the muscle, the more the impulse generated. The bigger the muscle, the more the impulse. So when you have done echo in this patient, you are seeing left ventricular wall thickness. Dr. Judy is shouting, hypertrophic cardiomyopathy, hypertrophic cardiomyopathy. Another person is saying also, what if it's restrictive? And the next thing we see is that the two of them already off their word coats. They are already throwing punches. Then someone just walks in and the person is like, don't fight. No, don't fight. There is a way we can settle this. Let's go and do ECG. So when you do ECG, if it's hypertrophy, you really expect the QRS complex to have that amplitude, usually. If it's restrictive in this regard, usually cardiac amyloidosis, if it's restrictive, you are going to see the QRS complex will even reduce. So that thickness is not in tandem with the amplitude of the QRS complex, and that is how you know that this is restrictive, specifically cardiac amyloidosis. And this is quite common with cardiac amyloidosis, thickness and QRS complex disparity. So don't forget that, in case that is what you see them put in question. All this BNP, you are not surprised anyways. BNP reflects myocardial stress and is strongly predictive of prognosis in cardiac amyloidosis. You call that NT-proBNP, in case you see that. But this is just the explanation I want to give you here. So which investigation again? Best imaging you want to do, echo. It will show you all those stuff we talked about. The most accurate test you must do is tissue biopsy. You take the cardiac, you do the tissue biopsy of the heart. So when you do the biopsy, you'll be able to see all these amyloid fibrae. Then you can also go ahead and do the mass spectrometry of them for you to know, is it ATTR or AL, for you to know which one you are dealing with. That will help you. What is the treatment? The treatment is just diuretic. They tell you don't bother yourself, don't bother to give yourself unnecessary headache. Just remember diuretic. That's the main stuff that will help. Then you can treat the underlying condition. If it's AL amyloidosis, so you can treat that. If it's ATTR, you might not really be able to influence that much, but don't forget. And if it's very bad, go and transplant the heart. So what, in summary, what have I been able to put across to you? How to identify restrictive. You usually see beyond heart in the question. That will give it out for you to say this is restrictive. Do you get? And then for amyloidosis, you will see that proteinuria will be in question, hepatomegaly and the likes. Come down to the cardiac hemochromatosis now. Just as I established with you with respect to the cardiac amyloidosis, you will see something related to heart, and you will also see some extra cardiac manifestation that makes it restrictive. Can you see? So what are those extra cardiac manifestations that will give this one out? Just something related to hemochromatosis that you already know. Usually, joint pain. Never forget joint pain. We know you are still going to meet at a joint today, but don't forget joint pain. Hemochromatosis, cardiac hemochromatosis, joint pain, arthritis. This patient has symptoms and signs of heart failure. Can you see? And you now ask again. You check, and I say, I'm also having joint pain and arthritis. They say I have arthritis. You now look away. You check. They say recently diagnosed diabetes too. You look away. No, that makes it cardiac hemochromatosis. The day you write that diagnosis down, you'll be very proud of yourself. You'll be so proud because it makes a lot of sense. It makes a lot of sense. So, joint pain, diabetes, liver cirrhosis, because all these iron, they usually generate free radicals in the name of Fenton reaction that damage all those places. So don't forget. Now, what is the best initial study you must do if you are suspecting cardiac? Don't forget that it's only history you've taken an examination and you are suspecting cardiac hemochromatosis. What is that best initial test you must put at the back of your mind that will give it out? And that is iron study. Ferritin level. If anything will happen, it is the ferritin that will first of all reflect it. Ferritin level. In case they are very specific, just for you to note that. Then to confirm it, in case you are dealing with hereditary hemochromatosis, maybe it's not acquired. You know, if it's acquired, you can be thinking towards maybe thalassemia, someone with thalassemia and the likes. Major. You can be thinking towards all those stuff. But for genetic, there is no history of, excessive blood transfusion and the likes. So, genetic, you are suspecting genetic. Like hereditary hemochromatosis, you can go and do genetic testing. Okay, so that's that. So, what is the treatment? Then you go and, first of all, address the heart failure. Just as you have already known. Then, remove the iron. Address the underlying cause. Remove the iron chelation. So iron chelation. And then you can also do what we call therapeutic phlebotomy. So I want you to note this. Under which condition do you give iron chelation therapy? You usually give this if there is organ involvement. So if there is no organ involvement, the patient is just having hemochromatosis and the organs are still looking well, phlebotomy, therapeutic phlebotomy can help. Let me just show you a question here, just for you to have an idea, basically, of how the question can come. 48-year-old male present with progressive fatigue, dyspnea on insertion, lower extremity edema. You're already suspecting heart failure, but those are just symptoms. You don't know what is going on. You now say he has a history of type 2DM and joint pain. So there is joint pain, there is type 2D. Now, physical examination reveal irregular heartbeat and signs of fluid overload. That's still related to the heart failure. And irregular heartbeat is related to, It's related to the arrhythmia that the patient could develop. Laboratory study shows elevated ferritin and transferrin. They ordered for this based on the way the patient presented. So that's why they ordered for this. Now say echo revealed dilated left ventricle with impaired systolic function. So because the patient can also have dilated cardiomyopathy anyway. And now say what is the next best step to confirm this diagnosis? So to confirm the diagnosis, what you should, don't forget that they've already done the iron study. So the next thing you do is the cardiac MRI. All right. So what the cardiac MRI will do is that it's going to reveal the iron load in the heart. Echo cannot pick it. Do you get it? Echo cannot pick it. So cardiac MRI will pick that. So best diagnostic test can detect and quantify myocardial iron overload. It's going the MRI, that MRI will show it. It's going to reveal it for us. That's for hemochromatosis. What about cardiac sarcoidosis? So just as I established for us, you will see beyond the heart compared to dilated and hypertrophy. So here you are seeing heart problem, something that looks like heart failure. You now check, you now see something related to sarcoidosis. So what are those specific things that are related to sarcoidosis? Number one, uveitis. Uveal system. Usually the anterior uveitis. We have anterior, we have the posterior. You can also have pan uveitis. Do you get it? So if it's anterior uveitis, so something will be wrong with the iris. Do you get it? The eyes also can be red around the limbus area. So just for you to be aware anyways. So you can see that uveitis, that will really give it a lymphadenopathy. Lymphadenopathy will also help you. Bilateral healer lymphadenopathy. So if you check the ones we've discussed before, we didn't mention anything like lymphadenopathy, this one, that one, and all those jargons. We didn't mention them. But here we mentioned lymphadenopathy, which means when you read your question, this patient is having heart failure, you now see lymphadenopathy alone. You don't even know what else. You just say cardiac sarcoidosis, and someone is asking you, how did you arrive at that diagnosis? You just say this patient is having lymphadenopathy. Say, what can't it be? Cardiac amyloidosis? You say no. That one is most likely going to come with macroglossia, easy bruising, proteinuria. What of hemochromatosis, cardiac hemochromatosis? You say that one is most likely going to come with joint pain. Do you get it? Diabetes, this one, that one. Sarcoidosis, lymphadenopathy, uveitis. Once you see that, just a cardiac sarcoidosis. And that's how you will nail the diagnosis here. All right. Initial, the investigation you can do again, just like the others too, ECG, echo, and all, and the likes. So what about the endocrine? Endocrine too, you will see something related to heart failure. You will now see something related to, that is, you will now see extension to the other part of the body apart from the heart, that is related to that particular hormone in question. So you call that acromegaly cardiomyopathy. That's one of them. So which means you will see heart failure from that elevated growth hormone. You will also see something related to growth hormone in other part of the body. That will give it, I just say that's you say that is a restrictive, what do you call it, cardiomyopathy, specifically acromegaly cardiomyopathy. So you sure we will see something related to excessive growth hormone in the patient body. Like what? Enlarged hand, enlarged feet, facial features, nose is big. The wife is shouting there. How come your nose is looking like this? And the likes. So you couple with heart failure symptoms, you now say this is acromegaly cardiomyopathy. What of diabetic cardiomyopathy? So you will see the heart failure symptoms. You will see something related to the diabetes anyway. In other part of the body. Do you get it? So that will give it out. They might say the patient has diabetes, has the heart failure symptoms, and you check. The iron study is not showing it. Nothing about all those stuff that could have also manifested that. So you say that is most likely diabetic cardiomyopathy. What are the drugs? I mentioned some of them the other time. Chemotherapy related cardiomyopathy. which means the patient must have been given a particular drug that can cause it. So a very good example is this patient on what anthracycline. So it can be dosorubicin and all manner of stuffs. So when you see that, just be like, that's the, you see in the exam they've tested this trastuzumab. Watch out for it. When we are dealing with breast cancer, we are going to look into all this stuff. Trastuzumab, watch out for this. Breast cancer, I think I'll be dealing with that in gynae. I know you have heard about cervical cancer, breast cancer, but I will take my time to simplify it for you so that you have an idea of how to think. You see, the thing about the exam is not stuff. It's about your thinking pattern. How are you thinking? That's the essence of the Concept Academy. Just to give you the opportunity to think, even in the midst of difficult questions. You are still looking at things in a special way. Like, the thing is so simple. That's all you need. It's not for us to come here and be describing the shape of trastuzumab for you. No. When you see it in question, what does it mean? What is the next thing you want to think about? And the likes. Alright, so cyclophosphamide is another one. Trastuzumab, they've tested this before in the exam. Watch out for it. This one they've tested, and this anthracycline, these two, they've tested them like water in your step 2 exam. So they will test it like they test it, very specific. So watch out for it. Once you see that, just say that, okay, this is the drug induced. 60-year-old woman with history of breast cancer is undergoing treatment with dosorubicin. She has completed 6 cycles of chemotherapy. On her routine follow-up visit, she complains of increasing fatigue and shortness of breath on insertion. Physical examination reveals bilateral lower extremity edema, gallop redeem, jugular venous distension. Echo shows left ventricular ejection fraction of 40. Which of the following is the most likely cause of her symptoms? So all you can see is symptoms and signs of what? Heart failure. And this patient has been on dosorubicin. So that means that this is due to drug. So this will be drug-induced cardiomyopathy. The answer is chemotherapy-related cardiomyopathy. So that's how you look at it in the exam. We've talked about this. All right. I think I am going to stop here. I think you've learned something, right?